This year has tested us. As a nation and a university. Yet, we've faced adversity many times throughout our long history. And we're no stranger to challenge. We know that complexity is challenging, but for us, it's inspiration to move forward. Forward in the pursuit of fundamental knowledge.
Hi, and welcome to Forward Fest. Hi, and welcome to Forward Fest. We're so glad that you're here engaging in some bold ideas, varied approaches, and forward thinking that make Princeton the special place that it is. We want to hear from you throughout a year of forward thinking, and particularly during Forward Fest. Be sure to tag any of your forward thinking posts on social media with hashtag #PrincetonForward. That includes any questions or comments you want to share with the Princetonians who will be broadcast here today. It's my pleasure to introduce to you the moderator of our Thinking Forward Public Health session, Dr. Celine Gounder, Princeton class of 1997. Celine is an infectious disease specialist, immunologist, and medical journalist. She will be leading a thoughtful discussion with 4 forward thinkers today. Celine, take it away.
Welcome to Princeton University's Forward Fest and today's first session, Thinking Forward Public Health. I'm Dr. Celine Gounder. I'm from Princeton's class of 1997, and I'm delighted to be with you here today. I'm really looking forward to a wide-ranging discussion on the many ways that Princeton researchers have pivoted their research and broadened their thinking in their areas of expertise in response to the coronavirus pandemic. I'm thrilled to be joined today by 4 of Princeton's forward thinkers in this area. With us today are Ann Case, the Alexander Stewart 1886 Professor of Economics and Public Affairs, Sir Angus Deaton, the Dwight D. Eisenhower Professor of International Affairs, Emeritus, Professor of Economics and International Affairs, Emeritus, and 2015 Nobel Laureate. Ramanand Lakshminarayan, Senior Research Scholar in the Princeton Environmental Institute, and Jessica Metcalf, Associate Professor of Ecology and Evolutionary Biology and Public Affairs, and co-director of the Program in Global Health and Health Policy. We'll actually start by welcoming Jessica to the discussion.
Hi, Celine.
Hi, thanks for joining us. So I just want to start by saying that most of the folks in our audience are not immunologists. And by the way, I'm an epidemiologist, not an immunologist. So it's been a little while since I myself studied some of these things in medical school. Before we jump into your research, could you just give us a short primer? What are the different branches of the immune system? So, innate versus adaptive, antibodies versus T cells.
Well, I'm going to start by saying I'm also not an immunologist, although I think it's incredibly fascinating. And the immune system is designed to try and detect, obviously, dangerous intruders in our body. And it does this either by looking for conserved signatures. So there's some parts of pathogens that they just can't change. So our immune system has what's called pattern recognition receptors that just looks for those signatures, which tell them there's a marauder. But it also, and that's very much the innate immune system, it also has a branch called the adaptive immune system that goes looking for markers of non-self, so patterns that clearly aren't part of our own organism, molecular signatures that suggest that something that is not part of our organism is present.
So many people, I think, have heard of antibodies, at least. That's a part of the immune system I think most people are familiar with. What are some of the other parts of the immune system that might be important for fighting off SARS-CoV-2?
So I think, I think one could talk all day about the immune system and still be oversimplifying, but it seems like so many pieces come into play in the context of SARS-CoV-2. So I mentioned the innate immune system, and we're seeing lots of suggestions that particular innate pathways are being impeded by this pathogen very cunningly. And these are protective lines that operate very early on in the infection. So this is the interferon pathway that you might have heard of. And once those have hopefully successfully launched, they then recruit a lot of kind of foot soldiers of the immune system to come into play that are again generalists, so part of the innate immunity that's just looking for general patterns of damage or signatures of problems. And then the two branches of the adaptive immune system will come into play, B cells and T cells largely. So B cells are the ones that produce antibodies, which are, you can sort of think of them as little shapes that glom onto the virus and stop it from operating, but also tag it so that your immune system, your innate immune system knows to go after it. T cells do something a little bit more complicated. One of the ways in which viruses would be able to evade the surveillance of the immune system would be just by hiding out and doing everything inside cells. So cells are mandated in some sense by our bodies to produce evidence that they haven't been invaded. So they chop up all the little molecules inside them and they show them on the surface of their cells. And T cells come by and check to make sure that everything looks like a version of self and not like some intruder. And if a signal that shouldn't be there is obvious, then things like cytotoxic T cells, they're called, basically T cells that kill cells, will swing into action because they'll know you've been invaded. If you are that cell that's producing the wrong signal, they know you've been invaded and they'll destroy it.
So might some branches of the immune system be more important depending on what you're looking for? For example, blocking transmission from one person to another versus the part of the immune system that might be more important in terms of reducing severity of disease?
So that's a great question, Celine. It brings up something that I didn't really emphasize, which is that the immune system does many things. Clearly, the reason we get sick is partly to do with just the sheer viral load. The viral is replicating and we're going to reach some level of viral load. The other part of it is that the immune system is a curiously dangerous line of defense. It is effectively killing your own cells, so it can overreact. And we think that's a large part of the issue associated with SARS-CoV-2 severity. So the immune system is probably the second most complicated thing in the universe, and all the different players probably get involved in all these different pieces. It's certainly the case, I think, that different components will be more or less relevant for transmission blocking versus clinical immunity. But it's very hard to pin down exactly which might be relevant when. I think at this stage, probably a clever immunologist would give a much crisper answer there.
So if you have COVID antibodies, does that mean you're immune?
The answer is we don't know yet. And the other answer is immune to what? So I think that, it's definitely the case that we are producing antibodies that can recognize this virus, or at least some of us are. Whether they are capable of neutralizing it in all situations is not clear. And whether, if they were able to neutralize it and were able to protect you from a secondary infection, how long that would last is also not clear. So the things that we need to figure that out is, one, a huge amount of data. So we need to be tracking what's happening to people who have been infected. We need to be collecting this sort of information, but we also need time. This is still, it feels like forever, but it is actually still a relatively short time that this pathogen has been circulating. So we need to have time to see what happens to people who have been previously infected before we can decide, before we can establish the degree to which we're at risk of secondary infection. Other coronaviruses do seem to not have persistent immunity. So once you've been infected, you're protected for a while, but then you're once again vulnerable to reinfection.
So why is it important for people to understand that just because you have antibodies, you may not be immune? We just don't know right now.
I think it's extraordinary how many people know so much more about the immune system than I would ever have imagined this time last year. And I think that if the better sense we have of who is and isn't protected within the population could potentially help shape how we move back. But of course, this is a very complicated issue in itself. I think it's, we need to understand the situation we're in order to project where we're going to be going forwards. The antibodies, so we're talking about both protection, but it also is a marker of exposure, which is perhaps a good sense of situational awareness, a good sense of how far this infection has got in our populations, which is quite tricky to get if you're just looking at cases. Because, we're only showing markers of being infected for a relatively narrow window of time, but we think that the marker of having been infected will last longer. So that gives you a better sense of what segment of the population might have been infected.
So why did my understanding is your prior research was really focused on the microbiome of humans, of animals. Why did you pivot to studying COVID antibodies?
Actually, I have done some work on the microbiome. I've also, a large chunk of my research within the context of the Princeton School of Public and International Affairs was on vaccine policy. So we did a lot of thinking about who is and isn't protected from infection by vaccination, specifically from measles. And as part of this work, with Brian Grenfell, my great colleague and friend here, we became really conscious of the fact that there's this kind of huge gap in the way we do surveillance for infectious diseases. We're always tracking cases. So we always kind of know who's infected right now, and even then we know it inadequately, as has become manifest over the last few months. But we're not tracking the kind of flip side of that coin, which is who is susceptible to infection and who isn't. Because of course, if everybody's immune to infection, especially for something like measles, then you really are in a very different place from if people aren't. And so we had started, we really felt that understanding this landscape of immunity would put us in a much better place in terms of public health, in terms of understanding where we can target vaccination, but also might change our understanding of the landscape of where we are generally in terms of everything from emergent pathogens to everything else. So for example, for coronaviruses, if we had a sense of what's normal, in some sense, of what the landscape of immunity should be in a normal January in America, so what my blood and your blood is showing as signals of markers of having been infected to a particular coronavirus, we might have been able to detect anomalies. We might have been able to detect an excess of cross-reactive antibodies, because these things often look like each other, so our immune system will somewhat react to things it's seen previously. And our analogy is always, when the people who were designing the weather forecasts suddenly deployed buoys all across the oceans of the world to measure sea surface temperature, and that increased the precision of weather forecasting by an enormous amount. We have this remarkable and delicate sensor of the landscape of infectious diseases, which is all of our immune systems, but we're just not using it. So we had been thinking broadly about the potential for antibodies, but also other immune measures for really revolutionizing how we understand the landscape of public health. In tandem, I do think a lot about evolution of immune systems and how male and female immune systems are different. This also in the context of microbiome research. So it all kind of came together, and we moved really swiftly to try and think about what that meant right now.
And finally, Jessica, I just want to understand, why is it in particular that what will we learn from how coronavirus is spreading both on campus as well as in the community?
So I think we want to learn everything everywhere, right? So the campus is also an important part. What motivated that measure was certainly partly understanding spread. And spread is, I think the university has worked remarkably hard to try and figure out how we can optimize testing and situational awareness to ensure that people can come back. It's not clear whether all those pieces are in place yet, but a lot of hard work is going on, because essentially you want to be able to identify where cases might break through. And to do that, you need to know where they've been and where they're likely to go. And testing for antibodies, but also testing for active infections is a large part of this. The other part of it is that there's still so much that's unknown about this virus, and the piece that we were interested in contributing alongside the situational awareness for Princeton was how variable different individuals' antibody reactions or immune system reactions in general are, since it seems like very similar people can sort of experience this infection extremely differently. So that was certainly part of our motivation.
Well, Jessica, I'm super excited to see what you find and how we might be able to leverage that in controlling COVID in the future. Thank you for joining us, and you'll be back with us for the Q&A at the end, I think.
Thanks so much.
So after this short break, we'll travel to India for a short conversation with Ramanan Lakshminarayan about a major study he conducted there with real global impact. We're back with Ramanan Lakshminarayan. Ramanan, you and I actually had a conversation offline recently about a study you published quite recently in Science about contact tracing efforts in India and what this has shown about children and super spreaders. I just want to start with asking you if you could just explain the scale and scope of this study that you guys conducted in southern India.
Right. Thanks, Celine, and it's a pleasure to speak with you again. So this study was in the context of contact tracing that was being done by public health authorities in 2 states in the south of India, Andhra Pradesh and Tamil Nadu. Together, these states are about 120 million population, so roughly about a third the size of the United States. And as Indian states go, they have reasonably good public health systems, and they were able to trace contacts of literally hundreds of thousands of people. We had data on about 85,000 primary cases, and then 3 million contacts of these had been tested but we had reliable data on all sorts of things on about 575,000 contacts who had actually been tested. So it was a massive effort on the part of the states. It required something like 50 or 60,000 contact tracers working over the course of those 5-6 months to come up with that data. But it certainly told us a lot about how COVID was spreading in India.
So as somebody who has family in Tamil Nadu, it's sort of interesting to me. They're not in Andhra Pradesh. They're in Tamil Nadu, which is one of the 2 states that where you did this research, but these are not the wealthiest states in India. So why do these states have the capacity to do such excellent surveillance and contact tracing as opposed to other parts of India, or for that matter, as opposed to the US?
These 2 states have a legacy of public health. In one case, in Tamil Nadu, it goes back to the 1930s when a mumps outbreak prompted, the colonial rulers back then to put in place a public health cadre, which, stays till today. And Andhra Pradesh has post-independence, which means for the last, 70, 80 years has built that capacity, but they really honed that capacity for contact tracing in the context of HIV. During the AIDS epidemic, it was widely predicted that India would end up having the world's largest AIDS epidemic. It turned out to not be the case, but it was largely because of really efficient contact tracing that was done both backwards and forwards to be able to identify, people who'd come in contact with someone who'd had HIV. And that same apparatus went to work right after COVID became an issue. And I don't think there are many places in the world that can go out and trace 3 million contacts. I mean, 3 million is a population of many countries. So it's absolutely mind-boggling. But if anyone can do it, these states can.
So can you talk us through how the contact tracing is done? What are the logistics of all that?
So the logistics are really incredible. So it starts with someone getting tested positive, and then someone calls that person and finds out who they've been in contact with, really close contacts based on whether they shared, whether they lived in the same household, they shared, linen, or they were, shared a meal together. So there's a pretty extensive questionnaire that is laid out in front of the person who has been tested positive. But there's a step even before that, which is literally every week, twice in a week, someone shows up. Typically, it's a young woman who shows up at the household and asks people, is there anyone with symptoms of COVID? And she'll typically carry a notepad and really write this down for the entire population. And this was done really efficiently in some places and really helped tamp down the epidemic in places like Madurai, which would have had a much bigger epidemic if it hadn't been for that. But that just requires a huge amount of manpower, like I said, and that was fortunately trained and available, and then they were able to gear up to put more of these in place.
So one of the challenges to contact tracers in the United States is that people don't always want to cooperate and answer their questions. What was the experience with this in India?
I don't think there was as much of an issue with people not being truthful about contacts, particularly because everyone sort of sees this as a national emergency, and they were keen on sort of sharing to make sure that they hadn't transmitted to someone else. I am sure there are people who probably didn't reveal all of their contacts, but on average, in our study, we had 7 tested contacts and about 14 identified contacts per every infected individual. So clearly people were not shy about providing information. And in some cases, it was a question of tracking down everyone who'd been on a small bus along with the primary case to find out, what had happened to them. It's amazing how they were able to do it. Clearly not perfect, but certainly impressive how far they got.
Yeah, it's really quite impressive. Knowing what I know about contact tracing here in the US, we don't approach anywhere near something like that. Now let's drill down a little bit more on your science paper. How were the contacts different from the index cases? So the index case being the first person we pick up and the contacts being the people that index case was in contact with. And what does that tell us about patterns of transmission in India?
We had about 85,000 index cases and about 575,000 contacts who'd been tested. And the contacts were a little younger, a little more male than the index cases. But when we looked at transmission probabilities, we found two things. One is that people were far more likely to transmit infection to people of their same age group, the same age cohort. So kids transmitted to kids, adults to adults, and the elderly to elderly, which was surprising because India has a lot of multi-generational households, and one would have thought that there'd be a lot of cross-generational transmission in a country like this compared to, say in the US, where the elderly are, normally cohorted by themselves into maybe, senior citizen homes or things of that nature. But that was not the case. It was a lot of age-specific cohorting, which is consistent with sociology studies, which talk about, who mixes with whom. The second thing that was interesting was that, children of all ages seem to transmit infection. They receive the infection primarily from adults. So adults between the age of 20 to 50 were really accounted for the bulk of transmission. So they were the ones who were giving the infection to other age groups whenever there was cross-age transmission going on. But there was cross-age transmission going on from all age groups. Kids were giving it to people of all age groups, not as efficiently as the ones, in the age 20 to 50. But older children, particularly above the age of 10, were not that different from people from the age of 20 to 30, for instance. So a lot of things that came as surprises, because this was an unusual period of time when, like in most of the world, schools had been shut down. So, we couldn't really understand how kids had the opportunity to transmit to so many other children. Workplaces had been shut down for a large period of that time. But a lot of transmission was happening, both in households, like in all other countries, and certainly out of the community and workplaces as well.
So in the US, as you know, there's been a lot of debate as to whether kids can spread COVID. And based on some of the best data that's out there, at least prior to your study, the best data seems to have been from South Korea. What does your research say about this, and why some of the differences with the South Korean data?
The similarities with the South Korean data, and just to explain, the South Korean study was about, they had a sample size about 8% of our sample size, so still substantial. And there were remarkable similarities. For instance, the risk of transmitting COVID to someone in your household, if one person was positive, the risk that other people would get it was about 1 in 10. It was the same in China as well. So remarkable that countries that were so different that, the same probabilities, whether it's India, South Korea, or China. Similarly, the risk of transmission to someone in the community was about 1 in 40, surprising again. And again, the other South Korean study didn't really look at people traveling together. We found that the risk of transmitting to someone who one traveled with for more than 6 hours, who was within 3 seats of that person, and these were typically trains or buses, they were not planes, was about 80%, so quite substantial. But getting to children, this is, our understanding of this is certainly evolving. There was first a period of time where, because there were so few children infected in China, that there was certainly a feeling that children were not affected as much, and certainly that they didn't play a significant role in transmission of the disease. I think that has now evolved, and I think the data from India seem to suggest that children, particularly above the age of 10, can be effective transmitters of the disease. Now, we now know from the US, from various parts of the country, from states opening up or schools opening up, to see if there have been major outbreaks. The answer is there have been not, but these have been under circumstances when there has been a significant amount of caution taken and testing and so forth. So I don't think we have a clear picture on this yet, but different parts of the world tell us different things. And the Indian data seem to suggest that the kids are playing a role in the transmission chain. And I think we still need to sort that out for how it might work in the US. And certainly there are age differences. Younger children certainly seem to play a smaller role everywhere. It's the older kids and the adolescents that pose a risk, anywhere, whether in the US or in India.
And finally, Ramanan, what would you advise parents here in the US based on your research and the other research? And might that be different for a younger child than for an older child?
The main risk of children going to school, I guess, is, of course, we have to remember that this is balancing out the benefits of education and them, mixing with other kids and so forth, that, that has value. And certainly we need to take that into consideration. The second is that social distancing and, consistent mask wearing might be difficult because children by nature, just get close to other kids. So you can't expect them to follow the rules like you might expect with adults. I'm not sure adults follow the rules either, but at least we expect them to. But certainly it seems to be the case that younger children, are less efficient than the older ones, if there is a differential there at all. But a lot of the risk really comes down to whether there are older parents in the as in grandparents living in the household. And although India has announced that schools are free to open, very few schools have actually opened because parents are reluctant to send their kids to school because of these multi-generational households where they're scared that the child might come home with COVID and infect the grandparent, and that would be a risk that they don't really want to take. And I think it may be very different in the US where we don't necessarily have that kind of multi-generational families. So I think people should take precautions that is consistent with their family structure and risk. And I don't think there's a single answer everywhere.
Right. Tailoring to your family specific circumstances and where in the country you might be as well.
That's right.
Well, thank you so much, Ramanan. We'll bring both Ramanan and Jessica back a little later for our panel discussion. But first, we're going to speak with Sir Angus Deaton and Anne Case about their latest work and its potential link to the coronavirus pandemic. They'll be back with me after a short break. So for quite a while, I've been wanting to speak to the two people who are here with me now, Sir Angus Deaton and Anne Case. So thank you so much for joining the panel today. I just want to start by providing some definitions here. Much of your work over the last 5+ years has been around this idea of deaths of despair. For people who may not be familiar with your work, what are deaths of despair?
Sure, and thank you for inviting us. We're delighted to be here. So deaths of despair was a shorthand we came up with to cover deaths from suicide, alcoholism, and drug overdose. It wasn't meant to particularly define what the despair was, and we really were using it just as a shorthand, but the media picked it up and it took on a life of its own, the term.
And suicide is sort of the ultimate death of despair. And one of the ideas we wanted to get across is that these other deaths, which were rising very rapidly in our data, had this sort of self-inflicted part to them.
It's all death by one's own hand in one way or another. And sometimes it's very hard for the coroner or medical examiner to know for sure what the intent was. So when we bin these things together, we don't have to worry that we don't know whether it was purposeful or it was just something that came about because a person had fallen into a very dark place.
So prior to the pandemic, maybe start with Angus this time, what was driving these deaths of despair?
Well, there's various levels at which you can look at this. So first of all, there's the cause of death on the death certificates, which we've talked about. But we sort of tracked it back to a sort of, as Durkheim would have done in the, late 1800s, to a sort of ultimate social failure and the lack of social support for a group of people. We knew very early on, from the very first paper we wrote, that these deaths of despair were largely happening to people without a 4-year college degree. And that for those of us who have a 4-year college degree from Princeton or elsewhere, we're sort of seem to be largely exempt from these deaths of despair. It's important to note that about 1/3 of the population have a 4-year college degree. So it's the majority who do not. And what we did was we traced back, and much of this is in our book now, through the terrible things that were happening to people's lives. A huge increase in pain, for instance, an increase in disability, decreases in the ability to socialize with other people, decreases in church attendance, the decrease in union membership, marriages are coming apart. And in the end, we feel that it has to do with the failure of the labor market to provide good jobs for people with less education, and we can talk about automation and globalization and the various other forces, including failures of our healthcare system, that are making that much worse than it ought to be.
And how did the two of you pick up on these deaths of despair in your research?
So it was really quite by accident. We were looking at suicide, and we realized that suicides were rising, and then we thought, well, let's look at that in perspective. Like, how big is this relative to what's happening overall to people in midlife? And we were stunned by the fact that for whites, and we looked at whites primarily because suicide rates are much, much higher for whites, we found that all-cause mortality was rising, which it wasn't supposed to do. All-cause mortality fell dramatically throughout the 20th century, and it continues to fall in other rich countries. But our mortality rates in midlife were rising. And that had flown under the radar. No one had seen that. We took it on the road. We went to friends in medical schools and showed this, and we assumed that people must know that was happening, but it came as a surprise to everyone. It was happening invisibly, actually.
And Angus, how do some of those trends in terms of deaths of despair parallel, perhaps in terms of the population affected, who's been hardest hit by COVID? Is there an overlap there?
Yeah, we spent a lot of time recently thinking about that. And COVID is reinforcing some of the inequalities that we're writing about. And there's some different ones. So it's not exactly the same. So, one of the things that we all know about is, and I think we talked about it already, those of us who are better educated have a much higher chance of being able to go on working on Zoom or whatever, or working remotely. Whereas less educated people often don't have that option, and many of them might be in service jobs, or they're in transport, or they're in retail or something, where they either have a good chance of losing their job, in which case they lose money, or they have a higher chance of getting infected. So also there's a racial dimension to this, some of which was there before, which is, when we first did our work, the Black community was doing relatively well, but that stopped around 2014, and as fentanyl got into inner cities, and you began to see rising Black mortality too. And so Blacks have been quite badly affected by COVID, presumably mostly because of their occupation and where they live, and multi-generational households and transport patterns and things like that. Maybe even worse healthcare has played a part too. What is really different is two things. One is Hispanics, who are dying in much larger numbers than they ought to. Not in total numbers, but they're much younger than the general population. And so they shouldn't be, and they are. So that's new. And the other thing that's different is women. And not so much in terms of dying, but being affected by the pandemic. And it's largely because women have still the primary responsibility for bringing up kids. And that's been upset people's work arrangements in very serious way during COVID. So many women have had to give up their jobs, or, and so there's a high rate of unemployment among women.
But there are some other similarities. One of the things that we talk about in the book is that people have lost their trust in government. They feel like the system is rigged against them. And so they also don't trust when the government tells them, you really should wear a mask, you really should social distance. Of course, that message has been terribly mixed. in this pandemic, but that sense of not trusting word that's coming to them. And both the epidemic that we write about and the COVID pandemic highlight problems in the healthcare system. So different problems, but we think that that the fact that it's less educated people, the fact that there's so little trust in government, and the fact that the healthcare system is actually not helping in either of these, well, in our epidemic especially, are similarities between the two.
What are some of the weaknesses that both deaths of despair as well as the coronavirus pandemic highlighted with respect to our healthcare system, with respect to employer-based health insurance?
Yeah, well, the one that's become obvious to everyone, and we didn't write about it very much in the book, is that, you know, if employment goes away on a mass scale, as it did, especially at the beginning of the pandemic, then when you lose your job, you lose your health insurance too. And a lot of people have recovered it, but there's millions of people who were left naked without healthcare insurance. That does not happen in other rich countries in the world, where people couldn't get out of health insurance if they like. But the other, we did also in the book spend a lot of time talking about employer-based health insurance, and that interacts with the incredible cost of our healthcare system to mean that for a job, if you're going to have a job with health insurance, your employer has to come up with $20,000 or more for family policy, or about $11,000 for an individual policy. That prices those people out of the market, essentially. So a lot of good jobs for less skilled workers in large corporations, for instance, have simply gone away because no one's paying that colossal amount of money. So the employer-based healthcare system has these two strikes against it, one during the pandemic, but one, it was helping destroy the low-skilled labor market. And we put that pretty close to the heart of generating deaths of despair.
It's the case, for example, now with this epidemic, that if I present at an ED, I might face bills that I cannot pay, even if my insurance is taken by the hospital that the ED is attached to, right? Because a lot of the emergency departments have been bought up by private equity, who can charge whatever they want and then send the bill on to someone who had no idea that they weren't covered in the emergency department.
That's something we don't know about yet, but the chances are there'll be a lot of people, in spite of the CARES Act and attempts to stop this, who are left with unpayable medical bills at the end of this pandemic.
Yeah, that's really concerning. And of course, we'll have to see what happens starting in November with the Supreme Court and the Affordable Care Act, whether there will be further changes in terms of how people get health insurance. For many months, many have predicted that lockdowns and social distancing could lead to a big increase in deaths from suicide and opioid overdose. And maybe starting with you, do you agree with that prediction?
You know, we don't agree with that prediction. It might happen, but for example, when we look at the deaths of despair through the Great Recession, which was our last big economic shock, these mortality rates were rising before it, they rose through it, and they rose after it. So we think that the concurrent economic conditions don't necessarily tell you whether or not this is going to spark an increase in this. We think it's more the long run, long term hope for the future, hope for you and your family that causes people to despair. And most recently, for example, what we saw was that drug overdose deaths, which took a holiday a bit in 2018, came roaring back in 2019 and into the beginning of 2020. So we do worry that these drug overdose deaths are going to continue to rise, and that suicide rates may continue to rise, although there's we won't know what fraction of that was caused by COVID, if any of it, but we think that there's no reason to believe long after there's a vaccine or treatments for COVID that the kinds of dysfunctions that we write about are just magically going to disappear. We're going to have to do something else if we want to get at the heart of that.
Right. The evidence is not very strong either. There's one study from the state of Massachusetts showing there's been no increase in suicides. I read that the other day. But these data are slow to come, and they have to be handled by the coroners. They have to put a cause of death. It has to go back to the CDC, and we won't know that. But what Anne says about opioids is incredibly important, because it was rising through 2019, and there's a data system that picks up ED visits for overdoses, and we know that much quicker than we know the overdoses. And that was increasing into the beginning of 2020, before the pandemic came. And of course, everybody in the press is looking for this to happen. So they look and say, opioid deaths are rising like crazy. Well, I mean, it's not clear. It's pretty clear they are rising, but whether it had anything to do with the pandemic, we don't know.
The one thing that's different is that people are socially isolated. And that wasn't the case, for example, during the Great Recession. And social isolation really probably does put people at risk. I mean, we know a really good journalist who happened to know someone in Michigan who, because he was socially isolated, overdosed and died. So, anecdotal evidence, and that's terribly, terribly sad. But we don't know yet. We have anecdotal evidence of the fact that if I overdose alone, I'm at much higher risk of dying than if I overdose with someone who can call for Narcan, naloxone, to be administered, and that can naturally bring people back from an opioid overdose. So time will tell, but unfortunately we think that the underlying causes that were causing people to turn to drugs and alcohol or to take their lives, we haven't dealt with those either. So those are going to be there still to be dealt with once we have a vaccine, once we have treatments, once we hopefully are back on our feet again.
So would it be fair to say that any association between the coronavirus pandemic and whether it's overdose or suicide would really be mediated through possibly long-term socioeconomic impacts, or, as you mentioned, the case of somebody who is using opioids, overdoses, and is isolated, so not found by someone else? I think a lot of people assume that it's loneliness that's what's driving some of these patterns.
Could be. I just don't think we know yet. And, there's lots of plausible hypotheses out there. It's clear that treatment has been disrupted. So, it's people who are in addiction treatment, for instance, may have had trouble, especially early in the pandemic, in getting back to that. So, but, the world is never going to be quite the same after this pandemic. And therefore, I don't think there's a normal that we can expect to go back to, sort of idea. And so we certainly wouldn't want to say that this is a blip, and when we're out of here, everything will be the same as it was before. We just don't know.
Now, Anne, you have written, you and Angus have written in your book about the connection between American capitalism and the deaths of despair. Why do you make that connection? Do we not see deaths of despair in other countries?
No, we're not seeing deaths of despair in other countries. Well, Britain a small amount, but Britain may be following us in other ways as well with the economy. But we're hoping we can help people connect the dots. That one of the reasons that people fall prey to drugs or alcohol or suicide is because they don't see themselves as being able to have a good life, a life where they feel they have some status or some meaning. And we think the way the labor market has turned against these low-skilled workers is a large part of that. Now, why does the labor market turn against them, or what's happening? Well, part of it is that with rent seeking, which is just over the top now, where companies, corporations go to Washington, they look for special favors for themselves. For example, there are 5 lobbyists from the healthcare industry for every member of Congress. So, for example, they're powerful enough that with the first relief bill for COVID, where billions of dollars were being given to big pharma to work on vaccines, the lobbyists were able to take any teeth out of the bill that would allow there to be some sort of price ceiling or price controls for vaccines once they were developed. So there are these powerful forces that we think need to be reined in, but we think first among equals might be the healthcare industry, given that we have the most expensive healthcare system in the world, and using many metrics, including life expectancy, we have the poorest markers for health in the rich world. So something's wrong with this picture, and a lot of it has to do with prices.
We're sort of making the case that not that capitalism is bad. We think, we're not in favor of abolishing capitalism, but capitalism needs to be tamed, because left to itself, you get gigantic inequalities evolving, and then these inequalities feed on themselves because the people who are getting rich are very good at corrupting government or influencing government in order to keep pouring money into them. And the healthcare sector is not the only sector that's doing this, but we're spending 20%, nearly 20% of GDP, $1.05. And estimates by the Institute of Medicine and various other people as to the amount of that we could get back if we spent just as much as Switzerland, which is the second most expensive place, would be more than is $1 trillion a year, which is more than a quarter more than we spend on our entire military. And we're arguing in the book that a lot of that is coming out of the lives of unskilled workers. And so it's a flawed capitalism. It's a capitalism that shouldn't work that way. It's the lack of competition. And, it basically is crazy to try and pretend the healthcare system can be provided through the market. No other country in the world does that, and we shouldn't be doing it either.
Well, I certainly have more questions for both of you, and we'll get a chance to delve into some of that in a little bit more in the panel. Thank you so much. And please stay where you are, speaking to our audience now, because after this break, we will bring back all of today's forward thinkers for a lively discussion. So stay tuned. Welcome back. We're still here with Jessica Metcalf, Ramanan Lakshminarayan, Sir Angus Deaton, and Ann Case. So I have a few questions from the audience already. First of all, each of the speakers talked about the length of time for study data to come in. When we need to know new information quickly, as we do now, is there something that could be done about testing and study protocols, using different methods or review and approval processes? And we actually have a nice sampling of the laboratory test kind of study, the epidemiological study, and the broad socioeconomic impact. So maybe we can start from the more micro to the macro. Perhaps Jessica, if you'd like to take a stab at that first.
I think my colleagues who actually work in laboratories would be quite tickled to hear me described as such. But I think that there are certainly paths. The regulatory slowdowns have been one of the many frustrating things about the response to this pandemic. Stepping aside from the fact that, much of the ways in which data flow is controlled in this country is to do with privatization of healthcare, right? So it's much easier if you have a nationalized health system, but that's to the side. My colleague Michael Minna at Harvard has been very enthusiastic at pushing the idea of rapid less sensitive tests, but that you would take regularly that might give you a sense of how infectious people were. So I think that's very important to remember that silver bullet's not going to be the answer here. It's going to be many approaches that are going to help get us out of this, but a more nimble and responsive regulatory apparatus would certainly help, because I think we have the technology for many of these things.
Yeah, I've spoken to Michael actually about that. And unfortunately, what you really need is a separate FDA approval process for a screening public health test versus a clinical diagnostic test. And I know he's been having conversations with them and has been sort of running into walls there. Ramanan, what do you think about study timelines and protocols and how the research is being done?
So it's certainly the case that there are lots more data available in the world than what gets to be available for studies, which can arguably help everyone. So that goes without question. Now, the rules of the game for making these data available are typically set for, what I would call peacetime, when we don't have this serious urgency, and in our balance between taking care of individual privacy and patient rights, we lean more in that direction than towards urgency, because nothing is really, that life-threatening when you're doing studies outside of a pandemic. During a pandemic, things change entirely. And we were fortunate to have 2 states in India which were willing to share data. And they were doing it not because they wanted a paper out of it. They were willing to share data because every week I had to get in front of those states and their senior bureaucrats and provide a briefing to them on their own data to help them determine their policies for the coming week and the weeks ahead. I think that is one way in which to engage, which is if data are made useful back to bureaucrats or policymakers who control these data, then they're more willing to share it. But certainly, the pandemic is an unusual time, and I think it's throwing up a lot of questions about how we appropriately balance between the needs of patients and the needs of public health.
And Anne and Angus, it seems to me that the socioeconomic kind of research is probably the hardest to put on fast forward. Is there anything that can be done more quickly and perhaps inform policies, for example, like the CARES Act, that kind of relief bill?
Well, yes and no. It's really complicated. I think the CDC, which is under enormous pressure, has done a relatively good job. But in the long run, we have a public health system that's not set up to deliver fast results, because, the deaths are collected by the states, the National Vital Statistics System is collected by the states, and the coroners pass them up to the states, and then the states send them to the CDC. If you were designing a system to work in a pandemic, you wouldn't do it that way because it takes too long. There have been suspicions of data withholding of this administration, and that there's a lot of data the administration has and the DHS has that is not being released and could be released. There was an episode in which the New York Times put a FOIA request into the CDC to get data by race and age, which the CDC has not been applying. But when they published the data, it was perfectly clear that the CDC was quite right not to release it. It was very incomplete. It was biased. You'd have to know a lot in order to be able to interpret it properly. And the CDC, I think, was quite properly holding it back. So I don't think there was any sense of evil doing or misdeeds there. Of course, many people now would suspect this administration of doing almost anything in that regard. We've tried to press the CDC to release educational data, which they're very sympathetic to, but they haven't done. And presumably they're just under a lot of pressure. And, I couldn't make a case for saying it's as important as some of the things that Jess has talked about, for example, which would, I think, serve the public good better than, having the education. One thing I should say, I don't know how many of you have seen the work that Raj Chetty and his team have been doing at Harvard, which is they've made deals with credit card companies, with lots of private sector companies, with banks and all the rest of it. So if you go to their website, you'll see weekly information on consumer spending by different classes of people and so on. So that's set up an amazing data system, which is very, very rapidly available. Of course, again, it's imperfect. You really would like the full national accounts, but nevertheless, it's been very important to see who's being hurt, who's spending, how spending patterns are changing, and who's benefiting, well, not benefiting, but who's being hurt most during the pandemic.
We have another question. This one's from Facebook, Jennifer Hahn. Why aren't we putting all of our efforts into 5 or so tests, all companies, all countries, all efforts, instead of the US? For example, having over 200 tests all under emergency use authorization, and none are very good. I think this may have something to do with the Defense Production Act, but I will let you take that one, Jessica.
I think, Celine, I think you might have a much better sense of this than I do. I do think it's hard to know what will work, given that these are tests which have to interface with all of human behavior as well, right? And all of the nuances of how people administer them, how the data is collated. So I don't think we know for sure what the perfect product looks like. And so I think there is still some role for diversity, but I think 200 probably sounds like a lot. I'd love to hear what you think, Celine, as well on that.
Yeah, I mean, so first of all, there are 3 main categories of tests here. You have the PCR tests, which are really testing for active infections. So those are looking for the genetic material of the virus. That's where you do the nasal swab. So secondly, you have the antibody test, which is what Jessica is studying, which really tells you something about exposure to coronavirus. We still don't know if it really means anything about immunity. And then thirdly, you have the antigen test, which is what Dr. Michael Minna at Harvard and others are really advocating that we scale up dramatically. They're not as sensitive as the PCR tests. So you will miss some proportion of people who are currently infected with the antigen test. But the thought is that the people you're missing are not really infectious. And so it's less important from a public health perspective. If you're really trying to identify the people who might be spreading the virus, the antigen test may actually be a much better tool. It's also much cheaper, faster. This is the kind of test that's similar to a urine pregnancy test you do at home. But I think, as we alluded to earlier, there's some major issues in terms of having separate FDA approval pathways for something that's really a public health test versus a clinical diagnostic test. And I do think that the Defense Production Act should have been used to really scale up testing. So that's my take on it. We also have a question from Mark Cox on Facebook, who says that this intelligent discussion is like a breath of fresh air for his intellect. It's a nice compliment, thank you. Asks whether the asymptomatic contagion of coronavirus is the key difference between it and the flu virus. Is this why coronavirus might stay under the radar and undetected for such a long period of time? Maybe Jessica and Ramanan on that one.
So I think that asymptomatic transmission, it's this combination of asymptomatic transmission and very severe disease in some, which makes this such an intractable problem. Certainly the asymptomatic transmission is what sets this virus apart from its sort of coronavirus predecessor, SARS-CoV-1, which was as virulent, but very easy to detect. And so it was relatively easy to shut it down because if people were infected, you knew it. Influenza is something which can also be asymptomatic. One of there's many differences in how it presents and what its case fatality is, but the sort of main difference is many of us have been living it for a long time. So there is some immunity within the population to influenza. It's not a complete sort of virgin soil for the virus to spread across. Ram, I think there may be bits I'm missing.
No, I think that was perfect. I have nothing to add.
We have another question on Facebook. JD Leza, I apologize if I pronounced that incorrectly. Are there disparities among economic groups in terms of deaths of despair? How much would income and wealth need to improve to reduce the highest rates of deaths of despair? And are non-economic interventions likely to be more beneficial than economic solutions? So maybe, Anne, if you want to start with that one.
So we know the education of people who died because that's on the death certificate, but we don't know their income or their occupation or whether their mother loved them. None of that, which we would love to have, do we have. So we were able to document quite well that these deaths of despair go well up the income distribution. It's not just people who haven't finished high school or only have a high school degree. Even people with an associate's degree are at very high risk relative to people with a BA, which have been almost untouched. So it's not necessarily about poverty. In fact, the poorest people as a group in America would be African Americans who, until fentanyl enters the street drug supply, we're seeing their rates of death from alcohol and drugs fall dramatically. Hispanics did very, very well. So it seemed to be something that was happening to this privileged group, privileged by the color of their skin, at least. But certainly people who found themselves at risk because they didn't know where their lives were going. Now, how do you deal with that, right? So I have a really nice conversation going on with someone who's a professor at Stanford who would say, you can't really think about fixing all the economic things you need to fix. Let's just go in there and make sure that we have better prevention for either alcohol or drug overdose. No one knows how to handle suicide, but maybe it's better to try to like nail this where you can than try to take the long view and try to do it through better jobs, better wages, better prospects. I don't know if you want to add anything.
No, I agree with that. I mean, we're not going to fix the better jobs quickly, but we've really got to fix our healthcare system, and that we think COVID might actually be an opportunity for that, because the flaws are sort of on full display in a way that they really weren't before. And a lot of people who were happy with their healthcare insurance before don't have it anymore.
We want to say to all the doctors out there, we love doctors. I mean, it's not that we know that like the majority of people who are caregivers are real caregivers. It's just that the system in which they're operating has gotten out of control.
A lot of doctors are victims here too.
Well, I'm a doctor. I'm a practicing doctor. I see patients at Bellevue in New York, and I think most doctors like me would argue or would agree that the healthcare system is dysfunctional and is not working for most anybody right now. Let me ask this question for really the entire group. There's been a resurrection of this idea of herd immunity recently with the Great Barrington Declaration, and then Dr. Scott Atlas, the neuroradiologist who's on the White House Corona Task Force, invited the 3 initial signers of that declaration to the White House. And then in response, a number of public health experts and scientists, for full transparency, me included, signed on to the John Snow memo, arguing against this idea of natural herd immunity. And I think it's important to distinguish natural versus vaccine-based herd immunity. If we could maybe starting with Jessica, then Ramana, then Anne and Angus, speak to what your take is on this argument for herd immunity.
Well, as you know, Celine, of course, herd immunity is a real thing. It's technically it is the proportion of the population that is infected where one infected individual results in less than one other infection. And it's herd immunity derived by vaccination has long been one of the great social goods around vaccination. So it really hurts to hear it thrown around in this sort of very thoughtless, I think, and fashion. The issue in this particular scenario is that to get to natural herd immunity, so many people would have to die, and it's just not a tenable approach, I think. I think that the situation has polarized oddly. I don't think anyone's saying just let it rip wildly. people have this notion that we might be able to shield vulnerable populations, but experience to date suggests that we're just not very good at doing that. Our human populations are just too intermingled, and so it does not seem that that is a tractable approach. And of course, these are all bad decisions. No one wants to stay in lockdown forever. So I think that for me, the thing that has frustrated me the most is how slow we've been to learn about what works in terms of reducing transmission, what interventions are most effective, and what we can do to, wait until the ideal situation would be if we had a vaccine. Again, I'm very suspicious of any silver bullets, and I think the vaccination itself is not going to magically arrive and make everything better. But I don't think that that just pretending like nothing's happening is actually tenable. It was mildly incoherent, sorry.
Ramanan, I know you've written some op-eds on this concept of herd immunity. What's your take here?
So I'll build on what Jess said, and I agree with everything that she said. I wrote about this back in April, and I was writing in the context of India, where the reality of the situation is that herd immunity would be an unintended but a natural consequence of the inability of a country to control COVID. So it wouldn't be the result of a deliberate strategy. It would just be where things sort of started slowing down just because the disease was uncontrollable in that particular context. I wouldn't put the United States and India in the same bucket by any means. I think the US has vast resources at its disposal and could have done far better at controlling the epidemic than it has. And if it has reached this point, I think we all know why it's reached this point. It's because it wasn't taken seriously. India, on the other hand, I think I said this to you a few weeks ago, India and the US are different in that India had the leadership, but no public health system. And the US had the public health system, but no leadership. And it really goes to show you really need both. And having the public health system was not sufficient in the case of the United States, which is sad. And the thing that we don't realize is that acquiring COVID is not like a one shot, you get your immunity and then you're out of jail free. There are long-term consequences that we're beginning to understand more about that we didn't know about 3 or 4 months ago. It's not something that you really want to subject someone to, even if they were young, as a way of getting out of the situation. And last, I think we're setting up straw men which are not real. I think a lockdown as an idea was done first copying the Chinese because they couldn't control their epidemic initially, and then the Italians. But the lockdown was always a way to sort of, be like a short-term circuit breaker to stop the epidemic while things like mask wearing or distancing or other measures came into place. It was never meant to be a long-term solution. And it's been interpreted by some as being the counterfactual. That's really the long-term solution. And that's why there's so much, sort of pushback against lockdowns as really being the way to address it. I don't think a lockdown was ever a good idea for a long term in either India or the US or anywhere else. But if people are railing against it, that's because we haven't done the other things that would replace a lockdown, which are consistent mask wearing and social distancing. I think it's possible to get back to some semblance of economic activity with these precautions and without a lockdown. So it's a false dichotomy to say that we either control this with a lockdown or we go with herd immunity. That's simply incorrect in my view.
Maybe just a very quick addition. I think what we're seeing here a lot of the time is not what it seems to be. In that, if you read what happened in historical epidemics, the battles we're seeing here and the battles we're seeing in Europe happen every single time, or almost every single time. There's a battle between the merchants and there's a battle between the authorities in control, and the conflicts between business on the one hand and public health on the other go back to the very early days when quarantine was invented in the Adriatic Ocean in the 14th century. So, none of this is new. And I think a lot of what we're seeing is a disguise for something else that actually, the merchants don't want to go out there and say, don't shut us down, let it spread. So they come up with these various stories. But presumably a lot of it, a smart strategy depends a lot on the stuff that Ramanan has been doing, which is, to what extent can you shelter some groups and let other groups go to school, for example? These seem like really important questions. rather than talking about herd immunity.
Well, I just want to thank everyone here. There are a number of other questions I would love to ask, and I know there were some others from our audience in the queue. But just to keep everything on time, we are going to wrap up today's session. But until next time, please keep up the forward thinking.
Thank you.
Thank you for engaging in this Forward Fest. Be sure to keep the conversation going on social media with #PrincetonForward, and visit forwardthinking.princeton.edu to access more forward-thinking content, including a downloadable resource guide for this month's Forward Fest that will help you dive deeper into these ideas. Again, we're glad you've been a part of Forward Fest. Until next time, keep up the forward thinking.